subject of our lecture is valvular heart disease. Normal valve function: maintain forward flow and prevent reversal of flow. Valves open and close in response to pressure differences between cardiac chambers. There are two types of valves. One of them atrioventricular valves. The second is semilunar valves. Atrioventricular valves prevent backflow of blood from the ventricles into the atria. Semilunar valves prevent backflow of blood into the ventricle. Atrioventricular valves are following: tricuspid valve between location between the right atrium and right ventricle, and bicuspid valve or mitral valves, location between the left atrium and left ventricle. Semilunar valves, pulmonary semilunar valves, location at the opening between the right ventricle and the pulmonary trunk. Aortic semilunar valves, location at the opening between the left ventricle and the aorta. In this slide, you can see anatomy of the heart valves. There is aortic valves, pulmonary valves, mitral valves, tricuspid valves. This is the left ventricle, right atrium, left atrium, pulmonary trunk, and aorta. You can see here, this is the tricuspid valve, this is bicuspid valve, and aortic valves, and pulmonary valves. Work of the heart valves during the diastole and during the systole. During the diastole, this bicuspid and tricuspid valve is opening, and pulmonary valves and aortic valves are closing. During the systole, bicuspid valve and tricuspid valve are closed, and pulmonary valve and aortic valve are opening. Types of valve disease. There are three types of valve disease. One is in stenosis. Stenosis is when the valve opening becomes narrow and restricts blood flow. The second is prolapse. Prolapse is when a valve slips out of place or the valve flaps don't close properly. Next is regurgitation. Regurgitation is when blood leaks backward through the valve, sometimes due to prolapse. In this slide you can see stenosis and regurgitation. Valve doesn't open all the way, don't enough blood pass through in the first, and during the regurgitation, valve doesn't close all the way, so blood leaks backward. The kinds of valve disease. In aortic valve, there is two types of disease: aortic valve stenosis, and the second is aortic valve insufficiency or aortic regurgitation. Mitral valve also two types of disease: mitral valve stenosis and mitral insufficiency or mitral regurgitation. Tricuspid valve, there is tricuspid valve stenosis and tricuspid insufficiency or regurgitation. Pulmonary valve stenosis and pulmonary insufficiency or regurgitation. Abnormal valve function. Valve stenosis. Obstruction to valve flow during that pass of the cardiac cycle when the valve is normally open. Hemodynamic hallmark, pressure gradient. Valve regurgitation, insufficiency, incompetency. Inadequate valve closure, back leakage. A single valve can be both stenotic and regurgitant, but both lesions cannot be severe. Combination of valve lesions can coexist. Single disease process, different disease process. One valve lesion may cause another. Certain combinations are particularly burdensome, for example, aortic stenosis and mitral regurgitation. Valvular stenosis. The valve opening narrows. The valve leaflets may become fused or thickened that the valve cannot open freely, obstruct the normal flow of the blood. Effects. The chamber behind the stenotic valve is subject to greater stress, must generate more pressure, work hard to force blood through the narrowing opening. Initially, the heart compensates for the additional workload by gradual hypertrophy and dilation of the myocardium with heart failure. Valvular regurgitation, leakage or backflow of blood, results from incomplete closure of the valve due to scarring and retraction of valve leaflets or weakening of supporting structures. Effects. Causes the heart to pump the same blood twice, as the blood comes back into the chamber. The heart dilates to accommodate more blood. Ventricular dilation and hypertrophy eventually leads to heart failure. Principal causes of valve disease. Valve stenosis can be congenital, rheumatic carditis, or senile degeneration. Valve regurgitation can be congenital, rheumatic carditis, acute or chronic, infective endocarditis, valve ring dilation, for example in dilated cardiomyopathy, syphilitic aortitis, traumatic valve rupture, damage to chordae and papillary muscle due to myocardial infarction, and senile degeneration. Valvular heart disease, mitral stenosis, mitral regurgitation, aortic stenosis, aortic regurgitation, tricuspid stenosis, tricuspid regurgitation, pulmonary stenosis, and pulmonary regurgitation. Mitral valve disease, etiology. Mitral stenosis, 99.9% is rheumatic etiology. Congenital can be prosthetic valve stenosis, mitral annular calcification, left atrial myxoma. Acute mitral regurgitation due to infective endocarditis, ischemic heart disease, for example, papillary muscle rupture, mitral valve prolapse, chordal rupture, and chest trauma. Chronic mitral regurgitation, ischemic heart disease, papillary muscle dysfunction, inferior and posterior myocardial infarction. The second is mitral valve prolapse, infective endocarditis, rheumatic, prosthetic, mitral annular calcification, cardiomyopathy, left ventricular dilation, and idiopathic hypertrophic subaortal stenosis. Mitral stenosis. Etiology. Etiology of mitral stenosis are almost always rheumatic in origin. Older people can be caused by heavy calcification of mitral valve congestion and can be congenital, very rare. Pathophysiology. Narrowing of mitral valve can, in this case, left atrial pressure become is increased, and blood flow to left ventricle decrease. High pulmonary pressure and hypertrophy left atrium. Left pulmonary pressure is increasing and pulmonary congestion developing. Due to this one, oxygen and carbon dioxide ratio decreasing, exchanging. Due to this one, fatigue, dyspnea and orthopnea symptoms, and right-sided heart failure. Also, hypertrophy left atrium and decreased blood flow to left ventricle, decreasing cardiac output. There is left ventricular atrophy and fatigue. In this slide you can see left atrium enlargement. Due to left atrium enlargement, there is atrial fibrillation. Yes, due to atrial fibrillation, there is thromboembolism, like stroke, decreasing ventricular filling, left atrium pressure increasing, precipitate to edema, pulmonary edema and acute dyspnea, also developing palpitation. Due to this, left atrial pressure is increasing, high pressure ruptures pulmonary vessels. That is why there is hemoptysis. And due to this process, hoarseness, because of a compression of the left recurrent laryngeal nerve by a dilated left atrial pulmonary artery. This is called Ortner syndrome. Backward transmission of the elevated left atrial pressure, developing high pulmonary artery pressure, and then right ventricular hypertrophy and enlargement, and tricuspid regurgitation, and increasing right atrial pressure and development of right-sided heart failure. Symptoms: load P2 later becomes palpable, parasternal wavy, tricuspid regurgitation, due to this one hepatomegaly, and pulsatile liver and peripheral edema, jugular vein distension, prominent A waves and prominent V waves in venography. In the mitral stenosis, mitral valve area decreasing, high left atrial pressure, left atrium enlargement, compensation to attempt to lower left atrium pressure. Due to this one, left atrium transmitted to pulmonary venous system, high, left atrium remodeling, left atrium pressure elevated, and left atrium enlargement developing. Due to this one, atrial fibrillation, and due to this one, left atrium clot, which one is giving systemic thromboembolism. Pulmonary congestion, there is due to this one exertional dyspnea and pulmonary edema. Also, pulmonary vasal resistance is the increasing, and pulmonary hypertension. Right ventricular pressure overload is right ventricular due to this one right ventricular hypertrophy. Right ventricular dilates and fails with significant obstruction of flow from pulmonary vascular resistance and mitral stenosis. Cardiac output decrease, first with exercise, then at rest. Fatigue, due to this one, fatigue, dyspnea, and a decreasing functional capacity. Clinical features, symptoms, breathlessness, cough due to pulmonary congestion, chest pain due to pulmonary hypertension, hemoptysis due to pulmonary congestion or pulmonary hypertension, fatigue, low cardiac output, edema and ascites due to right heart failure, palpitation due to atrial fibrillation, and thromboembolic complications. Clinical feature, signs, atrial fibrillation or irregular pulse, mitral phases, abnormal flushing of the cheek that occur from cutaneous vasodilation in the setting of severe mitral valve stenosis. Auscultation, loud first heart sound, opening snap, treated by forceful opening of mitral valve. Mid-diastolic murmur in apex. Crepitation, pulmonary edema, effusion, raised pulmonary capillary pressure. Right ventricular heavy, load P2 is due to pulmonary hypertension. You can see this face of the patient with mitral stenosis. Investigation, ECG, right ventricular hypertrophy, tall R waves in the third, second leads. Chest X-ray, enlarged left atrium, and appendage, sign of pulmonary venous congestion. Echocardiography, thickened immobile cuts, reduced valve area, enlarged left atrium, reduced rate of diastolic filling of the left ventricle. Doppler shows pressure gradient across mitral valve. Cardiac catheterization shows pulmonary artery pressure and mitral stenosis. In this slide, the X-ray shows sign of mitral valve disease, and the echocardiogram confirmed mitral stenosis. It is the left atrial appendage is enlargement, and the degree is more than 90, 102. This angle is more than 102 degrees. In ECG, P mitrale, you can see in this ECG, P wave changes. In echocardiography, normal mitral valve area, and in the mitral valve area in mitral stenosis. Parasternal long axis view in diastole, showing diastolic doming and thickened, restricted posterior mitral valve leaflet. Long axis view of a patient with severe mitral stenosis, diastolic doming and hockey stick shape of the anterior mitral valve leaflet and restricted posterior leaflet. Extensive calcification of mitral annulus and leaflets in a calcification on the leaflets and annulus extending to the base of left at same patient, confirming this calcification shown as a bright echodem. Mitral leaflet articulate, anterior mitral leaflet showing donning. You can see this atrial, left atrium enlargement. Management. Medically, you can use anticoagulant to reduce the risk of systemic embolism, digoxin, beta blockers, or rate-limiting calcium antagonists to control ventricular rate in atrial fibrillation. Diuretic to control pulmonary congestion. Surgically, usually there is mitral balloon valvuloplasty, mitral valvulotomy, and valve replacement. In this you can see balloon mitral commissurotomy. You take the catheter, this coming balloon inside the left atrium, then the left ventricle, and there is commissurotomy. You can see in X-ray. 3D transesophageal echocardiogram, zoom mode acquisition of patient with severe rheumatic mitral stenosis viewing from left ventricular side. E. In the first, prior to balloon valvuloplasty mitral valve area calculated by the grid and 3D QLAB was 0.7 to 0.8 quadrat centimeter. In the second picture, you can see same view 2 days after successfully ballonoplasty. Both commissures are fully split. Mitral valve area calculated by same methods show increasing to 2.1 quadrat centimeter. 3D transesophageal echocardiography, full volume color acquisition of mitral valve of patient with history of severe mitral stenosis who underwent balloon valvuloplasty 1 year ago and now present with a severe mitral regurgitation, it is sometimes developing. Full volume acquisition of mitral with color suppressor showing over splitting of both commissure. Anterolateral commissure showed line of avulsion of this commissure toward E1 segment of anterior mitral leaflet. In the second picture you can see same view with color showed severe mitral regurgitation, jet origination mostly from the avulsion and second jet from oversplitting posteromedial commissure. Mitral regurgitation. Etiology. Rheumatic disease is the principal cause in countries where disease is common. Mitral valve prolapse, dilation of the left ventricle, and mitral valve ring. For example, in coronary artery disease, in cardiomyopathy, damage to valve cusp and chorda, rheumatic heart disease, and endocarditis, and ischemia or infarction of papillary muscles. Pathophysiology. Incomplete closure of mitral valve. Due to this one, backflow of blood to the left atrium. There is low volume of blood ejected by left ventricle and a decreased cardiac output, and also increased left atrial pressure. And this one, left atrial hypertrophy, high pulmonary pressure, high right ventricular pressure, and right-sided heart failure. Due to mitral stenosis, there is developing Laplace law. Stated by Laplace law, left ventricular wall stress is directly proportional to the cavity pressure and inversely proportional to wall thickness. Due to the added regurgitant volume, there is increase in left ventricular volume that leads to an increase in left ventricular cavity pressure, and it causes an increase in wall stress. If a hypertrophic response occurs, high thickness can return wall stress to normal. The hemodynamic changes in acute mitral regurgitation are more severe than those in chronic mitral regurgitation due, in part, to the lack of time for the left atrium and left ventricle to adapt to the mitral regurgitation. This is in contrast to chronic mitral regurgitation, where this adaptation have time to develop and typically preserve hemodynamic stability. Chronic mitral regurgitation pathophysiology. Volume load imposed in left atrium and left ventricle. Usually, it gradually high over time. Increased left ventricular and diastolic pressure and increased left atrial pressure. Compensatory dilation of left atrium and left ventricle to accommodate volume load at lower pressure. This helps relieve pulmonary congestion. Left ventricular hypertrophy, eccentric, stimulated by left ventricular dilation, high wall stress, Laplace law. Increasing preload, left ventricular hypertrophy, and reduced or normal afterload. Low resistance to left atrium provides unloading of left ventricle. Large total stroke volume, supranormal ejection fraction, and normal forward stroke volume. Mitral regurgitation, biggest mitral regurgitation. Viscous cycle in which whether left ventricular developing annual dilation and high increasing mitral regurgitation. Mitral regurgitation begins mitral regurgitation. In this case, there is a development low ejection fraction, high end systolic volume, contractility dysfunction, reducing forward stroke volume and cardiac output ratio, increasing left ventricular and diastolic volume to volume of and high left atrial pressure also. Reduced forward stroke volume and cardiac output, and pulmonary congestion and pulmonary hypertension is developing. Clinical manifestation symptoms: fatigue and weakness due to cardiac decreasing cardiac output, predominant complaint. Exertional dyspnea and cough, pulmonary congestion. Palpitation due to atrial fibrillation occur in 75% of the patients. Edema, ascites, these symptoms of right-sided heart failure. Clinical manifestation: signs: atrial fibrillation, cardiomegaly, apical pansystolic murmur, soft S1 and apical S3, Sign of pulmonary venous congestion, crepitation, pulmonary edema, or pulmonary effusions. Sign of pulmonary hypertension and right heart failure. Investigation. In ECG, you can see left atrial hypertrophy, left ventricular hypertrophy. In chest X-ray, enlarged left atrium, left ventricular. Pulmonary venous congestion also there is, and pulmonary edema. In echocardiography, dilated left atrium, left ventricular, structural abnormalities of mitral valve or prolapse. In Doppler, detect an quantitative regurgitation. Cardiac catheterization show dilated left atrium and left ventricle, mitral regurgitation, pulmonary hypertension, and coexisting coronary artery disease. This is the patient chest X-ray of the patient with mitral regurgitation, that is cardiomegaly. You can see three types of mitral valve regurgitation. The first is mild, you can see that small, moderate, and severe regurgitation. 2D transesophageal echocardiography views. In the first, 4-chamber views of mitral valve showing severe lathering of mitral leaflets. Coaptation depth equal 101 cm, that is the blue line, and coaptation length equal 0.6 cm. In the second picture you can see same view, the color Doppler demonstrating severe central and posteriorly directed jet of mitral regurgitation due to lack of leaflets coaptation, as seen in functional and ischemic mitral regurgitation. Management can be medically, like vasodilators, for example, angiotensin-converting enzyme inhibitors, diuretics. If atrial fibrillation present, we can use anticoagulants and digoxin. Surgically, mitral valve repair or mitral valve replacement. Aortic valve disease etiology. Aortic stenosis due to degenerative calcific congenital uni or bicuspid, rheumatic, prosthetic, acute aortic insufficiency, infective endocarditis, acute aortic dissection due to Marfan syndrome or chest trauma, chronic aortal insufficiency, aortic leaflet disease due to infective endocarditis, rheumatic, bicuspid aortic valve, prolapse, and congenital septal defect. Prosthetic, aortic rod disease, aortic aneurysm dissection, Marfan syndrome, connective tissue disorder, syphilis, hypertension, and ameloaortic ectasia. Aortic stenosis. Etiology. In infants, children, and adolescents. It can be congenital aortic stenosis, congenital subvalvular aortic stenosis. Young adults to mild age. Calcification and fibrosis of congenitally bicuspid aortic valve, rheumatic aortic stenosis, mild age to elderly, senile degenerative aortic stenosis, calcification of bicuspid valve, and rheumatic aortic stenosis. Pathophysiology: stiffening and narrowing of aortic valve. Due to this one can be left ventricular hypertrophy, decreasing cardiac output, and incomplete emptying of left atrium. In the first case, compression of coronary artery, and due to this one, decreased oxygen supply, and that is why myocardial ischemia and chest pain. Also, can be high myocardial needs, oxygen needs. That is why also myocardial ischemia and chest pain. Incomplete emptying of left atrium. Due to this one, pulmonary congestion, right-sided heart failure. Aortic stenosis is a progressive decrease in the area of the aortic valve. Decrease antegrade velocity when aortic area decrease at least by half. Adaptation by hypertrophy, early changes, diastolic dysfunction, decreased compliance, increased left ventricular diastolic pressure, unchanged contractility, normal stroke volume. Left changes, systolic dysfunction, myocardial ischemia, myocardial fibrosis, abnormal wall motion, decreased contractility, and decreased stroke volume. Due to this one, atrial fibrillation, mitral regurgitation, and in the end, heart failure. Clinical features: symptoms: mild or moderate stenosis, usually asymptomatic. Cardinal symptoms: cardiac output fails to rise to meet demand, exertional dyspnea, angina due to demands of hypertrophied left ventricle, exertional syncope, sudden death, episode of acute pulmonary edema. Clinical features: sign: ejection, systolic murmur, slow rising carotid pulse, thrusting apex beat, left ventricle pressure overload, narrow pulse pressure, sign of pulmonary venous congestion or crepitation. Investigations: in ECG, you can see left ventricular hypertrophy, left bundle branch block. In chest X-ray, may be normal, but otherwise enlarged left ventricle and dilated ascending aorta, posterior anterior view, calcified valve on lateral view. In echocardiography, calcified valve with restrictor opening and hypertrophy left ventricle. Doppler, measurement of severity of stenosis, detection of associated aortic regurgitation. Cardiac catheterization to identify coronary artery disease may be used to measure gradient between left ventricle and aorta. In this chest X-ray, you can see aortic stenosis. This is a frontal radiograph on left demonstrates isolated enlargement of the ascending aorta, white arrow. The left ventricle is enlarged, red arrow, and the heart is mildly enlarged upper. The lateral view on the right demonstrates calcification in the region of the aortic valve leaflets in the cycle. Generally, the aortic valve lies above the line drawing from the carina to the junction of the diaphragm with the anterior chest wall. The mitral valve lies below the line. You can see sign of a left ventricular hypertrophy, high R wave in AVL, in V5 and V6 leads, and deep S waves in first, in the second, in the third leads. Also, you can see deep S waves in AVF. There is also, you can see signs of left ventricular hypertrophy in the first leads, in leads V5 and V6. That is high R waves and negative T waves. Also, this picture in AVL, high tone waves and negative R, negative T waves, and deep S waves in third leads, in the V1 leads also. Echocardiographic assessment of aortic stenosis you can see in this slide. To the echocardiography, normal, you can see here, and aortic stenosis, cusp calcification and thickening, cusp motion limitation and doming left ventricular hypertrophy. You can see. Severity of aortic stenosis. The first is mild, the second is moderate, the third is severe aortic stenosis in echocardiography. Management. Asymptomatic aortic stenosis kept under review as the development of angina, syncope, symptoms of low cardiac output or heart failure has a poor prognosis and is an indication of prompt surgery. Moderate severe stenosis evaluate every 1-2 years with Doppler echocardiography to detect progression in severity. Symptomatic severe aortic stenosis need valves replacement. Congenital aortic stenosis they need aortic balloon valvuloplasty. Atrial fibrillation or post-valve replacement with a mechanical prosthesis. You can use anticoagulants in this case. In this slide, you can see transcatheter aortic valve replacement. This is the aortic valve, prosthetic aortic valve. Aortic regurgitation. Etiology can be congenital due to the bicuspid valve or disproportionate cusps. Acquired rheumatic disease, infective endocarditis, trauma, aortic dilation due to Marfan syndrome, aneurysm, dissection, and syphilis. Pathophysiology. Due to complete closure of the aortic valve, backflow of blood to left ventricle. Due to this one, left ventricular hypertrophy and dilation. Due to this one, left-sided heart failure, late stage, and decreased cardiac output. Also, increased left atrium pressure, left atrium hypertrophy. Due to this one, high pulmonary pressure and right ventricular pressure, and due to this one, right-sided heart failure in the late stage. Aortic regurgitation is like a diastolic regurgitation. Due to this one, there is increased left ventricular volume, increased stroke volume, aortic diastolic pressure decrease, and decrease effective stroke volume, fatigue. Due to this one, Myocardial oxygen supply also decrease. Myocardial ischemia and left ventricular failure. Aortic diastolic pressure also give myocardial oxygen supply decreasing, myocardial ischemia and left ventricular failure. Due to high stroke volume, there is left ventricular ejection time increase and decreased diastolic time, and left ventricular volume increase and increased left ventricular mass. Due to this one, increase myocardial oxygen consumption and left ventricular dysfunction. In the end, decreased left ventricular and diastolic pressure, and due to this one, dyspnea of patient develop. Clinical features: symptoms: mild or moderate aortic regurgitation, usually asymptomatic, because compensatory ventricular dilation and hypertrophy occur. Awareness of heartbeat, palpitations, particularly when lying on the left side, which results from increase in stroke volume. Severe aortic regurgitation, symptoms: breathlessness and angina. Clinical features signs: pulse changes, large volume or collapsing pulse, low diastolic and increased pulse pressure, pounding peripheral pulse, capillary pulsation in Nile bed with Quincke's sign, femoral bruits, pistol shot with Duresia sign, head nodding with pulse, the Misse sign, murmurs, early diastolic murmur, systolic murmur, increased stroke volume, often faint murmur, soft mild diastolic. Characteristic murmur is best heard to the left sternum during held expression. Other signs: displaced having apex beat, volume overload, presystolic impulse, forced sound, and crepitation if there is pulmonary venous congestion. Investigation: in ECG initially is normal, later left ventricular hypertrophy and T waves immersion. Chest X-ray: you can see cardiac dilation, maybe aortic dilation, and feature of the left heart failure. Echocardiography: dilated left ventricle, hyperdynamic left ventricle, fluttering anterior mitral left. In Doppler, you can see or detect reflux. Cardiac catheterization: dilated left ventricular, aortic regurgitation, and dilated aortic root. In this slide, you can see chest radiographs demonstrate enlargement of the left ventricle with an aortic configuration, reflect adaptive dilation seen in aortic regurgitation, frontal and lateral view. Electrocardiography in aortal regurgitation: also there is sign of left ventricular hypertrophy, high T wave, air wave in first, in AVL and V4, V5, V6 leads. Also deep S waves in AVF in the second and third leads. And also we can see deep C waves in V1, V2, V3 also, leads also. In echocardiography, you can see in left parasternal long axis view, you can see regurgitation blood from the aorta to left ventricle during the diastole. You can see there also aortic regurgitation from the aorta to the left ventricle. This is the jet. Management. Treatment may be required from underlying conditions such as endocarditis or syphilis, aortic regurgitation with symptoms, aortic valve replacement may be combined with aortic root replacement and coronary bypass surgery. Asymptomatic patients annually follow up with echocardiography for evidence of increasing ventricular size. Systolic BP should be controlled with vasodilating drugs such as nifedipine or angiotensin converting enzyme inhibitors. Tricuspid stenosis, esophagenesis, usually occur together with aortic or mitral stenosis, may be due to rheumatic heart disease. Decreased blood flow from right atrium to right ventricle. Decreased right ventricle output. Decreased left ventricle filling and decreased cardiac output. High systemic venous pressure. Pathophysiology. Blood flow to the right atrium decreasing. Tricuspid valve and right ventricle you can see in this slide. Backflow to the right atrium. Higher pressure right atrium, enlargement and hypertrophy right atrium. Due to this one, hepatomegaly. Then systemic venous return congestion. Due to this one, there is ascites. Narrowing of tricuspid orifice. Difficulty in passage of blood from right atrium to right ventricle. Blood begins to pool in right atrium and enlarges it. Due to this one, ventricles doesn't preserve blood and shrinks. Decreased cardiac output. And then systemic venous return congestion. Due to this one, hepatomegaly, ascites, and peripheral edema. Clinical features. Symptoms. Symptoms of right-sided heart failure. Symptoms of hepatomegaly, ascites, peripheral edema, neck vein engorgement. The second is low cardiac output. Due to this one, fatigue and hypotension. Signs of this stenosis: raised GVP, jugular vein pressure, and mild diastolic murmur, best heard at the lower left of right or right sternal edge. In this slide you can see apical four-chamber view from a patient with tricuspid stenosis, showing dominance of the tricuspid valve and turbulent colored flow across it. Note that this patient also has mitral stenosis. Management: valve replacement, valvulotomy, or balloon valvuloplasty. Tricuspid regurgitation. Esophagenesis common and is most frequently functional as a result of enlargement of right ventricle. An insufficient tricuspid valve allows blood to flow back into the right atrium, due to this one venous congestion and decreased right ventricular output and low blood flow towards the lungs. Causes. Primary can be rheumatic heart disease, endocarditis, particularly in injection drug users, IV injection, extends congenital anomaly. Secondary is right ventricular dilation due to chronic left heart failure. It is called functional tricuspid regurgitation. Right ventricular infarction and due to pulmonary hypertension or cor pulmonale. Clinical feature symptoms, usually non-specific, tiredness, reduced forward flow, edema, hepatic enlargement like venous congestion, because of venous congestion, signs, rising jugular vein pressure, pansystolic murmur, left sternal itch, and pulsative liver. In this slide you can see apical 4-chamber view at the echocardiogram showing significant tricuspid regurgitation at the collar Doppler. Management. Correction of the cause of right ventricular overload if tricuspid regurgitation is due to right ventricular dilation. Use of diuretics and vasodilators, treatment of congestive cardiac failure, valve repair or valve replacement. Pulmonary stenosis. Clinical features, symptoms, fatigue, dyspnea on exertion, and cyanosis. Poor weight gain or failure to thrive in infants. Hepatomegaly, ascites, edema. Signs. Ejection systolic murmur, loudest at the left upper sternum and radiating forward the left shoulder. Murmur often preceded by an ejection sound, click. Maybe wide splitting of second heart sound, delay in ventricular ejection. Maybe a trill, best felt when patients lean forward and breathe out. Investigation in ECG, right ventricular hypertrophy, in chest X-ray, posttonatic dilation in the pulmonary artery. In Doppler echocardiography, there is the definitive investigation, Doppler echocardiography. Management. Mild to moderate isolated pulmonary stenosis is relatively common and doesn't usually progress or require treatment. Severe pulmonary stenosis need percutaneous pulmonary balloon valvuloplasty or surgical valvulotomy. Pulmonary regurgitation, a rare condition, usually associated with pulmonary hypertension, which may be secondary of the disease of left side of the heart, primary pulmonary vascular disease, Eisenmenger syndrome, blood flow back into right ventricle, and due to this one right ventricle and atrium hypertrophy and symptoms of right-sided heart failure. Trivial pulmonary regurgitation is a frequent finding in normal individuals and has no clinical significance. Mitral valve prolapse. Causes: 2.4% population, we can see. Ratio is 2 women, 1 man. Serious mitral regurgitation more frequently in older men, more than 50 years old. Diverse pathogenetic mechanism of one or more portion of mitral valve apparatus: leaflets, chordae tendinea, papillary muscles, and valve annulus. Systolic click and mid to late systolic murmur equal major diagnostic criteria. Familial mitral valve prolapse is transmitted as autosomal trait, seen in mitral, aortic, skin, and skeletal phenotypes: aortic enlargement, non-specific skin and skeletal changes. 90% of Marfan disease, 6% of Ehlers-Danlos syndrome may be higher in type 4 collagenous syndrome, also associated with osteogenesis imperfect pseudoxanthoma elasticum, congenital malformation, Epstein, atrial septal disease, defect, ostium secundum, and Holt-Oram syndrome, hypertrophic cardiomyopathy also causes. Pathophysiology: myxomatous proliferation of mitral valve leaflets, prominent spongious component, increase of acid mucopolysaccharide. Cups, annulus, and chordae tendinea can all be affected by myxomatous proliferation. Myxomatous changes may result in annular dilation and calcification, further contribute to severe mitral regurgitation. Fibrosis and thickening of mitral valve leaflets, thinning and elongation of the chordae tendinea, ventricular friction lesion. Leaflets are grossly abnormal, redundant, and prolapsed. Site of endothelial disruption are common site of endocarditis or thrombus formation. Severity of mitral regurgitation depends on extent of prolapse. Chordae rupture at site of collagen degenerating and myxomatous changes increase mitral regurgitation. May also affect tricuspid, aortic, and pulmonary valve in the Marfan syndrome. 20% of mitral valve prolapse have prolapse in tricuspid and aortic valves on transthoracal echocardiography. Clinical presentation. Mitral valve is the most prolapse is the most common cause of isolated mitral regurgitation requiring surgical treatments in United States. First, cardiac condition predisposing patients to infective endocarditis. Asymptomatic can be and mitral valve prolapse syndrome, systolic non-ejection click, fatigue, palpitation, autonomic dysfunction, postural, orthostatic, anxiety, neuropsychiatric symptoms. There is syncope, presyncope, palpitation, chest discomfort, prolonged, atypical, not related to exertion, brief attacks, severe stabbing at the apex, may be related to abnormal tension on papillary muscle. If severe, mitral regurgitation, fatigue, dyspnea, exercise limitation. And there is symptomatic arrhythmia. Physical examination. Patients are slim and asthenic. Blood pressure normal or low. Orthostatic hypotension may be present. Straight back syndrome, scoliosis, pectus excavator. Mitral regurgitation may be absent to severe. Not ejection systolic click. Click often followed by a mid to late crescendo systolic murmur that continue to E2. When prolapse is severe, click is the onset of systole and may not be audible. Echocardiography. Prolapse on orbus leaflets below by at least 2 mm into the atrium during systole. Thickening of the involved leaflet to more than 5 mm supports the diagnosis. Severe myxomatosis disease, significant risk of severe mitral regurgitation. Leaflet redundancy, chordal elongation, annular dilation. Transesophageal echocardiography details the integrity of the valve apparatus, left ventricular size and function in secondary mitral regurgitation. Echo findings may be present in absence of click or murmur. In this slide you can see mitral valve prolapse. In this picture you can see mitral valve prolapse with regurgitation. In electrocardiography you can see inverted or biphasic T-wave, non-specific ST changes. Arrhythmia in mitral valve prolapse, there is ventricular premature beat extrasystole, supraventricular and ventricular tachyarrhythmias, AV block and sick sinus syndrome. Supraventricular tachycardia is the most common tachyarrhythmia. Increased mitral valve pressure prolapse in patients with Wolff-Parkinson-White syndrome. Association between mitral valve prolapse and prolongation of QT interval. Treatment. Aspirin if atrial fibrillation. Mitral valve repair is severe mitral regurgitation. There is same guidelines as mitral regurgitation. Possible in 90% of patients, and operative mortality is 1.6%. Thank you for attention.